Okay, so we are now moving on to Chapter 4. Chapter 4 is regional transport. What we are going to do in Chapter 4 is tear apart the nephron section by section and look at transport within each section of the nephron. So hold on tight, get ready to have some more fun with the nephron. Fluid that enters the proximal tubule is an isotonic ultrafiltrate, meaning that fluid that enters the proximal tubules is formed in Bowman's capsule. Therefore, that ultrafiltrate is isotonic to the plasma, which is 300 milliosmoles. So the concentration of the ultrafiltrate in the proximal tubule is equal to the concentration of the plasma. Okay, so the proximal tubule cell. This is a proximal tubule cell. Proximal tubule is a very busy cell. So let's take a look at this. Here we have the lumen of the proximal tubule. Here is the cell, right here. Here is the luminal membrane of the proximal tubule cell. Here is the basolateral membrane of the proximal tubule cell. Embedded in the basolateral membrane is your sodium-potassium ATPase, hydrolyzing ATP to actively pump out sodium and pump in potassium. That is a sodium-potassium ATPase. By doing this, you are setting up an electrochemical gradient. You have a low intracellular concentration of sodium here. Sodium moves inside the cell down its electrochemical gradient. As it does so, it pulls in glucose, amino acids, lactate, phosphate, and many other substances. This is secondary active transport. Many substances are reabsorbed here via secondary active transport. So the kidneys spend a lot of energy right here in the form of ATP. The kidneys use a lot of energy in the proximal tubules in the form of ATP. A lot of energy expenditure right here in the form of ATP. I want to make a special mention of phosphate right here. Phosphate is freely filtered at the glomeruli. Right here in the proximal tubules, we reabsorb 85% of the phosphate that is filtered. The other 15% is used to buffer acids in the distal tubules. We'll get back to that later on in this lecture, but that's a very important point. 85% of phosphate is reabsorbed right here in the proximal tubules. Now, what hormone inhibits reabsorption of phosphate right here? If you're saying PTH, you are correct. PTH inhibits reabsorption of phosphate right here in the proximal tubules, and that's important to know. Now later on we'll talk about what happens to the other 15% of phosphate. That's an important point to know. Now, bicarbonate deserves a special mention. This is bicarbonate that was filtered at Bowman's capsule. Let's talk about reabsorption of bicarbonate. In order to reabsorb bicarbonate, you need carbonic anhydrase. Carbonic anhydrase will convert bicarbonate and a proton to carbon dioxide and water. This carbon dioxide will diffuse into the cell right here. So this carbon dioxide diffuses into the cell. Then that carbon dioxide is converted by a carbonic anhydrase inside the cell to bicarbonate and a proton. That bicarbonate is then reabsorbed. This proton is then secreted into the lumen. And that's how bicarbonate is reabsorbed. Carbonic anhydrase is essential to reabsorption of bicarbonate in the proximal tubules. Now, what hormone activates this cotransporter? This is another very important transporter that utilizes secondary active transport. This is known as the sodium proton. This is an antiporter. Notice the sodium moves inside the cell down its electrochemical gradient. Protons are pumped out. This is antiport. This is another very important transporter. This transporter is activated by angiotensin II, leading to an increase in reabsorption of sodium and an increase in reabsorption of water. But it also leads to an increase in secretion of protons. And for every proton you secrete, you reabsorb a new bicarbonate molecule. So this leads to an increase in reabsorption of bicarbonate as well. So this transporter is activated by angiotensin II. And this is how bicarbonate is reabsorbed. Now, Here's a very important point. What would happen if this carrier stopped functioning? If this carrier stopped functioning, you would get what we call a proximal or type 2 renal tubular acidosis. You would cease to reabsorb bicarbonate. You would lose the ability to reabsorb bicarbonate. You would get a proximal tubule acidosis. This is a proximal tubule acidosis. What else could give you a proximal tubule acidosis? Well, you need carbonic anhydrase. So a carbonic anhydrase inhibitor, such as acetazolamide, would also give you a proximal renal tubular acidosis. So acetazolamide, carbonic anhydrase inhibitor, and dysfunctioning of this carrier. What do you call this disorder when this carrier ceases to function? This is called Fanconi syndrome. Fanconi syndrome is seen in children, and it's not only this carrier. You actually lose functioning of all of the carriers over here in the proximal tubules, and children present with glucosuria, amino acids in the urine. They lose the ability to reabsorb many of their nutrients, but in addition to that, they get a proximal RTA because they're not able to reabsorb bicarbonate. So that is the proximal renal tubular acidosis. That's the proximal RTA. Now, when you lose the ability to reabsorb bicarbonate, you get low serum bicarbonate. We call this a metabolic acidosis. The kidneys are able to maintain electron neutrality here by increasing reabsorption of chloride. So what you will see is a low serum bicarbonate, but you will see an elevated serum chloride. So we call this a hyperchloremic or non-anion gap metabolic acidosis. So an RTA will give you a hyperchloremic or non-anion gap metabolic acidosis. So you will not see an anion gap. What other electrolyte abnormality would you see here? If you're saying hypokalemia, you are correct. You will see a low serum potassium here. That is because of renal loss of potassium. Now, when you lose the ability to reabsorb bicarbonate, you lose bicarbonate in the urine, but in addition to losing bicarbonate, you lose sodium. Not just bicarbonate, you lose sodium bicarbonate in the urine, right? The bicarbonate will pull sodium. So you'll have renal losses of sodium bicarbonate, and the sodium bicarbonate will pull water. So you will actually diurese. You'll get an osmotic diuresis. You will lose sodium bicarbonate with water. You will get an osmotic diuresis. And we'll get to this when we get to the distal tubules. Anytime you have a diuresis, you have an increased flow rate in the distal tubules, you will lose potassium. So anything that gives you an increased flow in the distal tubules will give you renal losses of potassium. You will lose potassium. You will have renal losses of potassium. You will lose potassium in the urine because of increased flow rates. And hence, you will have a hypokalemia with the proximal RTA. Now, what will your urine pH be in the proximal RTA? I know some of you might be thinking, well, it should be elevated because you have bicarbonate in the urine. Well, initially, yes. Initially, the pH will be elevated, transiently. But where does this bicarbonate come from? This bicarbonate comes from your serum bicarbonate. This bicarbonate comes from your filtered load. Well, as your serum bicarbonate decreases, your filtered load decreases. And then this serum bicarbonate decreases. And then your excretion rate of bicarbonate decreases, and your urine pH will decrease. So the answer is, at steady state levels, in a proximal RTA, your urine pH is still low. And in a proximal RTA, you still have an acidic urine. And you will see in the distal RTA, you're not able to acidify the urine. But in the proximal RTA, you are still able to acidify the urine. And in the proximal RTA, you still have an acidic urine. And that's how you make the diagnosis. So we'll talk more about this when we get to the distal tubules. But in the proximal RTA, you will have an acidic urine because this bicarbonate comes from the filtered load. And the filtered load will decrease when you decrease the serum bicarbonate. And that is the proximal renal tubular acidosis. We will summarize this again later on in this lecture. So, approximately 2/3 of the sodium that was filtered at Bowman's capsule is reabsorbed in the proximal tubules. But also, 2/3 of the water that was filtered is reabsorbed at the proximal tubules. This is a very important point that they love to test you on the exam. At the end of the proximal tubules, there is no change in the osmolarity of the ultrafiltrate. It is the same. You reabsorb 2/3 of the water, 2/3 of the sodium. Therefore, there is no change in the osmolarity. It is still 300 milliosmoles. It is still the same. Another question they love to ask about is the following. In which portion of the kidneys is most of the water you filter reabsorbed? The answer is always one answer, the proximal tubules. Why? Right here on the slide. In the proximal tubules, you reabsorb 2/3 of the water you filter. That sounds like most to me. Even if ADH levels are elevated, that's still most of the water that is filtered, even in a setting of high ADH levels. And that's a constant value. So, in the proximal tubules, normally we reabsorb all the glucose that is filtered in the proximal tubules. This is via secondary active transport linked to sodium. And remember, the transporter that is responsible for this is the SGLT2 transporter. This is the predominant transporter in the kidneys. And remember, this is the transporter that gets saturated, and this is the transporter that now has drugs that target this to treat type 2 diabetes. Bicarbonate. 80 to 90% of the bicarbonate that is filtered is reabsorbed in the proximal tubules. In order to reabsorb bicarbonate, you need to use luminal carbonic anhydrase. Remember, this is inhibited by acetazolamide. They commonly like to ask about this. Bicarbonate combines with protons in the lumen and is converted to CO2 and water, again, which is catalyzed by luminal carbonic anhydrase. Protons are then pumped into the lumen in exchange for sodium by the sodium proton antiporter. Remember, the sodium proton antiporter is activated by angiotensin II. This is how bicarbonate is reabsorbed in the proximal tubules. So as I mentioned previously, angiotensin II directly stimulates the sodium proton antiporter. In volume-depleted states, angiotensin II levels increase, and that activates the sodium proton antiporter. This leads to an increase in reabsorption of sodium and water and bicarbonate in the proximal tubules. This contributes to a concept known as contraction alkalosis. The other contributor you'll see later on in this lecture is aldosterone, and we'll get to that a little bit later. So here's a clinical correlation for you. The exam likes to ask about a metabolic alkalosis. Here's an elderly patient who comes in with altered mental status. Hydrochlorothiazide is a common culprit in causing a metabolic alkalosis because what does hydrochlorothiazide do but it dehydrates you? It is a diuretic, and you have to be very careful with hydrochlorothiazide in the elderly because it can lead to volume contraction. It can dehydrate the elderly. It leads to a decrease in intravascular volume, leading to an increase in renin secretion, leading to an increase in angiotensin II as well as aldosterone. This can lead to a contraction alkalosis. You could also see this in some other cases of severe dehydration, such as sweating, severe cases of sweating, or vomiting. Not diarrhea, though. Important to realize in profuse diarrhea, you will lose bicarbonate in the stools, and in diarrhea, you will get a hyperchloremic or non-anion gap metabolic acidosis. So diarrhea will give you a hypochloremic or non-anion gap metabolic acidosis because you will lose bicarbonate in the stools. But vomiting could give you a metabolic alkalosis. Uric acid is a breakdown product of nucleotides. Xanthine oxidase catalyzes the reaction that forms uric acid. 90% of filtered uric acid is reabsorbed in the proximal tubules. If the filtered load of uric acid is high and the luminal pH is low, then more urate will exist in the form of uric acid, and this can precipitate the form of kidney stones. Now, the kidney stones will form in the collecting duct because the collecting duct is where you acidify the ultrafiltrate. The collecting duct is where your luminal pH is the lowest, and low pH is where uric acid forms, and low pH is where you will form uric acid stones. So kidney stones would form in the collecting duct in these patients. This can occur in patients with gout. This can occur in patients with tumor lysis syndrome. This is why when patients have malignancies and we're giving chemotherapy, we give allopurinol to prevent formation of uric acid stones. So secretion. Proximal tubules is where organic acids and cations are secreted and then cleared from circulation. This includes PAH, which we spoke about. This includes several drugs like penicillin, for example, atropine, as well as morphine. Energy requirements. So the proximal tubules require a lot of energy, very active. The proximal tubules are very active, require a lot of ATP because there are many sodium-potassium ATPases actively pumping sodium. You are reabsorbing a lot of sodium in the proximal tubules, and also many other substances via secondary active transport. This is the most energy-demanding process of the nephron, right here in the proximal tubules. Hence, this is the portion of the nephron that is the most prone to acute tubular necrosis in patients that have ischemia. So, when patients get ischemic acute tubular necrosis, it is the proximal tubules that is the most prone, as well as the thick ascending loop of Henle, because you will see they also require a lot of ATP to actively reabsorb electrolytes. You'll see that when we get to that section. So, this is an important slide to spend a few minutes on. They can ask you a bunch of questions based on this slide. So let's get into it. Proximal tubule transport. So what are we talking about? Well, whenever you get a graph, let's take a look at what's on the x-axis versus the y-axis. Here, on the y-axis, you're looking at the tubular filtrate to plasma concentration ratio. What does that mean? Well, let's take a look. Back at Bowman's capsule, you have filtration. So, if this is Bowman's capsule, and this is the plasma, you're filtering. Well, here in the plasma, you have a concentration of a substance. And then in Bowman's capsule, as you're filtering, you form a tubular filtrate. That's the ultrafiltrate that is formed by filtration. And the substances in the ultrafiltrate will also have a concentration. What we're looking at here is the tubular filtrate to plasma concentration ratio. Well, if a substance is freely filtered at Bowman's capsule, the plasma concentration of that substance will be equal to the tubular filtrate concentration of that substance. So, that's a substance that is freely filtered, like sodium, like chloride, like glucose. Those are your substances that are freely filtered at Bowman's capsule. And if that's the case, the tubular filtrate to plasma concentration ratio must be 1. If a substance is not freely filtered, for example, like albumin, then the plasma concentration will be greater than the tubular filtrate concentration, and the tubular filtrate to plasma concentration ratio would have to be less than 1, because the plasma concentration would be greater than the tubular filtrate concentration. So the ratio would have to be less than 1. Doesn't matter what it is, but it has to be less than 1. So, all of the substances that we're graphing now must be substances that are freely filtered, because in the beginning of the proximal tubule, or at Bowman's capsule, the tubular filtrate to plasma concentration ratio is 1. So all of these substances must be freely filtered. Now, down here on the x-axis, we're looking at what happens to the tubular filtrate to plasma concentration ratio as we move along from the beginning of the proximal tubules, or Bowman's capsule, to the end of the proximal tubules. And that's what we're looking at. Okay? Now, let's start with B. B's the one to start with. B, as you go from the beginning of the proximal tubule to the end of the proximal tubule, the tubular filtrate to plasma concentration ratio goes from 1 to 3. From 1 to 3. That is inulin. Why does that happen? Here's Bowman's capsule. Here's the proximal tubule. Inulin is freely filtered. As you move down the proximal tubule, why does the tubular filtrate concentration of inulin increase? Remember, inulin is not secreted. Inulin is not reabsorbed. What happens? Well, as you move down the proximal tubules, you reabsorb 2/3 of the water that was filtered. Therefore, the tubular filtrate to plasma concentration of inulin goes from 1 to 3 because you're not reabsorbing or secreting inulin, but you are reabsorbing 2/3 of the water that was filtered. So the concentration of inulin in the ultrafiltrate increases, and that's why it increases. How do you interfere with this? You stop reabsorbing water. They can ask you a question on the exam where they can say, as you move down the proximal tubules, the concentration of inulin stays at 1. What happened? You gave a drug that inhibited the sodium-potassium ATPase, and that stopped the reabsorption of free water, and the concentration of inulin didn't change. So that's why the concentration of inulin increases. Now, if you go back to the graph, anything that is above inulin on this graph, like A, for example, A goes all the way up to, let's say, 6. It's above inulin. Anything that's above inulin must be secreted. Bottom line. Anything that's above inulin must be secreted. PAH, creatinine. If it's above inulin on this graph, it is secreted. Now let's look at some other substances. C would be a substance that is reabsorbed, but reabsorbed less than water. Classic example here would be chloride. Chloride is reabsorbed less rapidly than water. Okay? Can you think of another one? Think of another one. What else is reabsorbed less rapidly than water? If you're saying urea, you are correct. If you're not saying urea, I don't know what else you're saying. Urea is the correct answer. D is an important line. Notice what happens to D. On line D, the concentration is not changing. That means that this substance is reabsorbed equally to water. That is sodium, that is potassium, that is calcium. The proximal tubules, you reabsorb 67% of the calcium that was filtered. You reabsorb 67% of potassium, 67% of sodium. Line E. E is a substance that is very well reabsorbed. Like what? What would be line E? Phosphate. You reabsorb 85% of your phosphate in the proximal tubules. Bicarbonate. You reabsorb 80 to 90% of your bicarbonate in the proximal tubules. E is a substance that is completely reabsorbed. F is a substance that is completely reabsorbed, like glucose or amino acids. Glucose or amino acids. That's a substance that is completely reabsorbed. Okay, so I would make sure you understand this graph. This is an excellent graph to be questioned on. So you will see maybe 1 or 2 questions on this. It's an excellent graph for renal physiology. The next segment is the loop of Henle. The fluid entering the loop of Henle is isotonic. This is the ultrafiltrate leaving the proximal tubules. So the osmolarity is 300 milliosmoles per liter. This volume is only 1/3 of the volume originally filtered at Bowman's space. The loop of Henle has a countercurrent flow that acts as a countercurrent multiplier. This creates a concentrated medullary interstitium. The osmolarity of the medulla reaches a maximum of 1200 milliosmoles per liter. This is due to electrolytes like sodium chloride as well as urea. This is necessary for reabsorption of free water by the collecting ducts. Now, the juxtamedullary nephrons are responsible for creating extremely high medullary osmolarity. This occurs because the surrounding vasorecta has very slow blood flow. This is crucial in maintaining a concentrated medullary interstitium, meaning that as blood flows through the vasorecta, because it's slow, a lot of the electrolytes and the urea that's being reabsorbed from the nephron sits in the medullary interstitium and is not washed away by the blood flow. And that's an important point. But this also means that the kidneys are prone to ischemic damage in low flow states because of the slow flow through the vasorecta. Here is a diagram of the loop of Henle. Why does the loop of Henle exist? Does it exist to confuse medical students? Well, most medical students would think, yes, that is the reason for the loop of Henle. But there's another reason. The purpose of the loop of Henle is to create a highly concentrated interstitial fluid deep in the medulla, right here. Why would you want to do that? To create an osmolar gradient. We call this the corticopapillary gradient. You want to create an osmolar gradient. Water always moves down an osmolar gradient. You see, if you do not have this osmolar gradient, you will not reabsorb free water. Now, the collecting ducts over here, where I like to say you fine-tune the urine. This is your last chance. Very important. This is where ADH works. This is where ADH increases the permeability of the collecting ducts to free water. And that leads to an increase in reabsorption of free water. But you could have all the permeability in the world. Without this osmolar gradient, you're not reabsorbing free water. And that's really the purpose of the loop of Henle, to create this osmolar gradient so you can reabsorb free water. And that's how it works. So let's take a better look at this. As you flow down the descending loop of Henle, the descending loop of Henle is very permeable to free water and very impermeable to electrolytes. So what happens? You reabsorb free water passively, and that concentrates the ultrafiltrate. So now your ultrafiltrate at the tip of the loop of Henle is very concentrated, 1200 milliosmol. That's highly concentrated. Now you go back up the ascending loop of Henle, and now you get to the thick ascending loop of Henle, which is impermeable to water. Now, by hydrolyzing ATP, you actively reabsorb electrolytes, and you keep water in the ultrafiltrate. Now the ultrafiltrate becomes very dilute. And all these electrolytes that you're reabsorbing, where do they go? Well, remember, the vasorecta surrounds here, but the flow is very slow, so you don't take a lot of those electrolytes away. A lot of them sit right over here in the interstitial fluid, and that creates this high osmolarity, and that creates this osmolar gradient, and that allows you to reabsorb free water from the collecting ducts. You need that osmolar gradient, and that's what the loop of Henle does. Sodium, potassium, 2-chloride, very important transporter. Loop diuretics inhibit this transporter. That's a very important point to know. What hormone activates this channel? If you're saying ADH, you are correct. ADH directly activates the sodium-potassium 2-chloride channel. By activating this, you increase the reabsorption of these electrolytes, and you increase the osmolar gradient. So you see what ADH does? ADH really is all about reabsorbing free water. ADH increases reabsorption of free water in 3 ways. 1, inserting aquaporin channels, increasing permeability of the collecting duct to free water. 2, increasing reabsorption of urea. Urea recycling, we call this urea recycling. Urea also adds to this osmolar gradient. And 3, activating the sodium potassium 2-chloride transporter. That will lead to an increased reabsorption of these electrolytes, and that will increase the osmolar gradient. So that's the important function of ADH. So this is what the loop of Henle really does. Now, the next segment is the early distal convoluted tubules. The early distal convoluted tubules are still impermeable to water. The early distal convoluted tubules have sodium chloride channels that are still actively reabsorbing electrolytes, and that is still a diluting segment. So the early distal convoluted tubules are still actively reabsorbing electrolytes, and they're still diluting the ultrafiltrate. So if they ask you which portion of the nephron has the most dilute ultrafiltrate, the answer is actually the early distal convoluted tubules, because the early distal convoluted tubules is still diluting the ultrafiltrate, because it's still actively reabsorbing electrolytes. So let me give you a clinical example of the importance of the loop of Henle. Let's say a patient comes in with hyponatremia due to SIADH. How do you know a patient has SIADH? Well, his serum osmolarity is low, his serum sodium is low, and his urine osmolarity is elevated, and he's euvolemic on exam. Now, the treatment for SIADH, as long as the patient does not have severe symptoms, is fluid restriction. This may be difficult to do in some patients. So what do we do in these situations? Well, we give the patient oral sodium, but in addition to that, we can give the patient a loop diuretic. How do loop diuretics help here? Well, loop diuretics, by inhibiting the sodium potassium 2-chloride transporter, remove the effect of the loop of Henle. They erase the loop of Henle. You stop reabsorbing the electrolytes, you stop placing them in the interstitium, and they remove the concentrating effect of the loop of Henle. You erase the corticopapillary gradient. You decrease reabsorption of free water from the collecting ducts. You can't do anything about the ADH levels because they're inappropriately high, hence the name. Can't do anything about that. But you can do something about the concentration gradient. So that's one thing you can do to treat SADH. You could also try ADH receptor blockers. We now have V2 receptor blockers for SADH, conivaptan and tolvaptan. You'll get this more in the pharmacology section, but you do have V2 receptor blockers for SADH, tolvaptan and conivaptan. You can also use those, but this is one option you can use to treat SADH. Okay, so this is a cell of the loop of Henle. I want to spend a minute to talk about a very important concept known as paracellular reabsorption. And this is how calcium and magnesium is reabsorbed in the loop of Henle. Now, pay attention here because this is not the distal tubules. PTH increases reabsorption of calcium in the distal convoluted tubules. I'm not talking about the distal convoluted tubules. I'm talking about the loop of Henle. Okay, this is a different part of the nephron. PTH has no effect here. In the loop of Henle, you reabsorb 25% of the calcium that you filter. You reabsorb 67% of the magnesium that you filter. You do this via the what we call paracellular effect of reabsorption. Here's how it works. The sodium 2-chloride potassium transporter reabsorbs all of these electrolytes, but it's electroneutral. Notice we're taking 2 cations, 2 anions. It's electroneutral. But when you do this, you create a very high intracellular concentration of potassium. You also have your sodium potassium ATPase on the basolateral side. Now you have potassium coming in from the luminal side, basolateral side. This creates a very high intracellular potassium concentration. On the luminal side, you have ungated potassium channels, and this creates a very high potassium leakage. As potassium leaks into the lumen of the nephron, the tubular fluid develops a positive charge. So now the tubular fluid develops a positive charge. And because of this positive charge, you repel these divalent cations, and this increases the reabsorption. This creates reabsorption of calcium and magnesium. And this is the concept of paracellular reabsorption, all due to the positive luminal charge. This is a positive luminal charge in the loop of Henle. This is paracellular reabsorption. Now, the calcium sensing receptor plays an important role here. The calcium sensing receptor works like this. As your serum calcium levels increase, calcium binds to and activates the calcium sensing receptor. When you activate the calcium sensing receptor, that sends a signal into the cell that couples to two G proteins, leading to the effect, the net effect, of inhibiting the sodium-potassium 2-chloride transporter. By reducing the activity of this transporter, you reduce the intracellular concentration of potassium, leading to less back leak of potassium. Because there's less back leak of potassium, you decrease the positive luminal potential. Because you decrease the positive luminal potential, you decrease the reabsorption of calcium. So, this is how elevated plasma concentration of calcium reduces paracellular reabsorption of calcium in the loop of Henle, by reducing the positive luminal potential here in the loop of Henle. And that makes sense, because if you have high calcium concentrations, you'd want to decrease reabsorption, and that will lead to increase in the excretion rate of calcium, increase in urinary calcium concentrations. Now, here's a bridge to pathology. Familial hypocalcuric hypercalcemia is an autosomal dominant genetic disorder where there is an inactivating mutation of the calcium sensing receptor. So now when your serum calcium levels become elevated, this calcium sensing receptor cannot sense that. So you cease to inhibit the sodium 2-chloride potassium channels. You continue to activate this transporter. You continue to have back leak of potassium. You continue to create a positive luminal charge. You continue to reabsorb calcium. That leads to a high serum calcium. That leads to a low urine calcium. Hence, familial hypocalcuric hypercalcemia. Low urine calcium, high serum calcium. You have lost the ability to inhibit paracellular reabsorption. You continue to reabsorb calcium, leading to low urine calcium levels. Loop diuretics block the sodium-potassium 2-chloride transporter, reducing reabsorption of these electrolytes. This also reduces calcium and magnesium reabsorption. So it's very important to realize that loop diuretics will lead to loss of all of these electrolytes, leading to hypomag, hypocalcemia, resulting in marked diuresis. Loop diuretics are your most potent diuretics because right here in the loop of Henle is where you reabsorb 25% of your sodium. So you can really get a very potent diuresis with loop diuretics, but you also lose a lot of electrolytes. You also lose potassium, and you can very commonly see hypokalemia, but you lose a lot of electrolytes with loop diuretics, and as a clinician, you have to be aware of this. You have to watch your electrolytes, and you have to replete your electrolytes. Bartter syndrome is a genetic mutation resulting in diminished function of the sodium-potassium 2-chloride transporter. It's just like being on a loop diuretic. It leads to low volume states. You're diuresing as if you were on a loop diuretic. It leads to increase in renin secretion and increase in aldosterone secretion. This is known as a secondary hyperaldosteronism. Patients will have hypokalemia, alkalosis, and elevated urine calcium levels. We'll get back to the effects of aldosterone a little bit later in this lecture. So, calcium sensing receptor. As I mentioned, the calcium sensing receptors are located in the basolateral membrane of the loop of Henle, and the calcium sensing receptors are coupled to a G protein. And when plasma concentration of calcium levels are elevated, the calcium will bind to and activate the calcium sensing receptor, leading to inactivation of the sodium 2-chloride potassium transporter, and that will inhibit reabsorption of calcium from the loop of Henle. And again, in familial hypocalcuric hypercalcemia, there's a genetic mutation. There's a genetic inactivating mutation of the calcium sensing receptor, and the calcium sensing receptor does not respond to plasma calcium. Think of it as the calcium sensing receptor being fooled into thinking that the plasma calcium is low when in fact it is elevated, and you're not able to inhibit the reabsorption of calcium. You continue to reabsorb calcium, leading to elevated plasma calcium and low urine calcium. These patients do have very low urine calcium levels. There are also calcium sensing receptors on the parathyroid gland. These receptors also are not functioning. These receptors are also mutated. So these receptors also will not respond to the hypercalcemia. Now, normally the calcium sensing receptors on the parathyroid glands, when they are bound to calcium and when they are activated by calcium, that leads to suppression of PTH. That leads to low PTH levels. Well, in familial hypocalcemic hypercalcemia, these receptors are inactive, and when calcium levels rise, you cannot activate these calcium sensing receptors. Therefore, you cannot shut down secretion of PTH, leading to high levels of PTH. So these patients will have elevated levels of PTH due to inability to inhibit PTH secretion. So these patients will have elevated PTH levels. So the test that tells you the difference between familial hypocalcemic hypercalcemia and primary hyperparathyroidism is the urine calcium levels. So you have to send the urine calcium levels. In primary hyperparathyroidism, the urine calcium levels will actually be very elevated, whereas in this disease, the urine calcium levels will be very low. And that's the test that tells you the difference, and that's important to know.